All right, guys. Obviously, with weather and other issues, occasionally we have to have a lecture online, and while not ideal, this is going to help us catch up. So, let me just say that this information is not exactly scintillating. I get that, but it is important. If you don't know how to document what you've done, that will be problematic. Documentation is at the core of everything that we do. So, above all, it's written evidence of nursing practice. And in fact, I want you to concentrate on the word evidence because that is what lets you know that this is in a legal framework. Not only is it very important communication wise for our patients to have a continuity of care, we need a good medical record, but it's what lawyers refer to when there are different lawsuits and things that go on. So if you don't have it written down, it's not done. And that's kind of a nursing moniker. If you didn't chart it, you didn't do it. So understand that this is highly important. Now, you are going to get a chance to practice a little bit of documentation. I do have an assignment for you that I will discuss with you in person, and that assignment is due on our last day of actual class. But right now, we're just going to try to lay the groundwork and get you some information on how to go about doing that. So, one of the main reasons we utilize a patient medical record is to help provide continuity and accountability. Continuity so that everyone knows where we left off. We can pick up where we left off instead of repeating things unnecessarily. And hopefully, this allows us to make sure that also everything gets done. That we don't, forget about a particular area that our patient needs to know about or be treated for, because that medical record gives us that roadmap, so to speak, of how we're supposed to get the patient from not well to well. So it's communication, and it's absolutely necessary for quality care. In fact, 80 to 85% of legal cases are determined by documentation, not by what people say in court, not any of that. It is all about what is written down, because again, we're back to if it wasn't documented, it wasn't done. So you can get up there and say, but I did do it all day long, but if it's not documented, then they're not going to believe that you did it. All right, so we use a patient medical record to plan our client's care. And while you guys haven't done care planning yet, we are getting there, and you will start to see how this all fits together. I promise it really does come together at some point. Communication is the primary reason we document, because we need a centralized source of information. Without that centralized source of information, we would be very fragmented. We would, have people just charting random things or doing random things, and everyone wouldn't be on the same page. Whereas having a centralized source of information helps us to provide continuity of care. That means that if I'm teaching a patient who is going home with a Foley catheter about that Foley catheter, I know that I need to teach them how to take care of the catheter, how to clean it, what to do and not to do, how to change that bag over to a leg bag so that they are more mobile, and then at night change it back to a bedside bag and do all that without contamination. We can't teach all that in one sitting to a patient. That would be completely overwhelming. So what I would do is teach my part. I would say maybe teach them how to cleanse the catheter, do basic cath care, use any Neosporin ointment, blah, blah, blah. I would document all of that. Then the next nurse that comes along realizes they don't need to teach what I taught. They need to jump off from where I left off and teach them the next segment. So even if that nurse and I don't ever get to talk about that, we both know what I've taught because I charted it. Okay? It also, again, prevents repetition. That patient doesn't want to hear that information again. They want to hear the next step. And so it prevents that nurse from having to go back and repeat everything that I've already said. It also prevents delays. We might not be able to send a patient home if we didn't get all of their teaching done. So that's going to cause delays. It's going to increase their hospital stay. It's going to increase their costs. It's going to probably get them in a little bit of hot water with their insurance company as well. So all the way around, this chart that we use for communication is epically important. And if you don't understand that and you think, this isn't, I mean, I get it's boring. I totally get that. Try teaching it twice a year. It's boring, I know. But it's so important to do this correctly that we have to spend some time on this information. Now, I've mentioned already that it is a legal document and it will be used in court, guys. No doubt about it. A lawyer is going to take any opportunity that they can to look at a medical record and use it to their advantage. All right? There are things that we can do to prevent them from using it, quote unquote, against us, but that's going to be something that you will learn over time. Now, this part is a little sticky. The information in the medical record, the actual information, is considered property of the patient. However, the record, meaning the actual medical record, is considered property of the agency. So this means a patient or their significant other or whatever, they just can't pick up a medical record and take it out of the building and say, well, this is mine. The information contained within it is theirs, but the actual record of that information belongs to the agency. So the patient can request copies, and the agency will have to comply with that. But the actual medical record is considered property of the agency, and it is illegal for a patient to attempt to remove it. One of the things we use a medical record for is research. Now, we always think about research projects as this person sets up their dependent and independent variables, and they set up a project, and everybody who's going to be in it knows that they're going to be in it in advance, and it's an upfront and advanced kind of thing. But actually, some research is done on the back end. If we're trying to decide which method to do something is better, and some doctors do it one way and some doctors do it the other way, we can go back and look at medical records where the patient's already been long since discharged and home, but we can look at the two different procedures and see which patient outcomes appear to be better. And that's solely based on what's written in the medical record. It's not actively engaging a patient in a research project at that point. So it's all about going back and looking at that information. We also use them for healthcare education. I mean, you're going to want to be in that medical record. You are going to learn a great deal by kind of tooling around that medical record, whether it's a paper record and you start flipping through and reading doctor's orders or reading the doctor's notes or the nurse's notes, or it's a computerized record and you get to click through different things and see all this valuable information. Clearly, nursing students, need access to that so they can learn their way around a medical record. Medical records are used for other things as well. Quality assurance monitoring, sometimes called QA or QI, also risk assessment is what they will sometimes call it as well. It's used to monitor care and competence, and it basically tries to take a look, again, on the back end, once a patient has already been through the system, and tries to go back and look at the chart and say, hey, did we do everything that we were supposed to do up to our standard of care? In other words, did the patient receive the care that they should have? Or is there a place where the ball was dropped? And if it was dropped, not necessarily who dropped it, it's not about placing blame, it's part of what part of our process allowed that to happen. Because if we don't have a process in place that prevents those kind of breaches in continuity of care to happen, then we need to reassess how we're going about doing that and come up with a new process that prevents us from making those mistakes. One of the biggest reasons somebody can be successfully litigated against is no attempt on an agency's part to fix a problem. If they're aware of a problem, but they're not doing anything to fix that problem, that looks very bad. Even if a problem happens, if the agency is actively involved in trying to help prevent that problem in the future and finding a solution, they're less likely to be found liable if they're actively trying to find a solution. Another reason we use our documentation is to collect statistics. Some statistics reporting is required by law, things like morbidity and mortality rates, infection rates post-procedure. Some of those are just absolutely required. But it also can help us anticipate and plan for any future healthcare needs. Maybe we figure out by looking through this medical record or all of these medical records that when patients come in with a certain problem, there's a lot, there's an increased risk that they end up with XYZ infection. So then we can take steps to make sure that they don't get that infection. So those statistics are very helpful for us in the long run. Not so much right at when it's happening, but when we can go back and take a look at what we've already done and try to make changes to make it better. Okay, other reasons that we document, accrediting and licensing. One of the big things that JCAHO is always looking for when they come is what we're doing with our documentation and how we're going about doing it. Now let me just take a quick sidelight here and explain why JCAHO, the Joint Commission on Accreditation of Healthcare Organizations, or just now what we call the Joint Commission, is an important facet. Most hospitals they need to be accredited by the Center for Medicaid and Medicare. And if they are not, then really bad things happen. Like they get no reimbursement for the care that they've provided under Medicare or Medicaid. It wouldn't take long of that happening to actually put a hospital financially under, meaning they would have to potentially close. So hospitals don't like to, have a situation where they could potentially lose funding. So if the Center for Medicare and Medicaid have a particular set of guidelines that they have to follow, and they're set at a particular level, JCAHO has their own guidelines, and they elevate that standard. They take the standard to slightly above what the government requires. Now, how does this benefit the hospital? Well, if the hospital is meeting JCAHO standards, then by definition, they are already meeting the CMMS standards. And if they were only accredited by CMMS, the Medicaid and Medicare Center, if they make a mistake and they, don't immediately fix it on their own, they can lose their reimbursement. Whereas if JCAHO finds a mistake, JCAHO will give them a very short period of time, but a period of time to fix their mistake. And all the while, CMMS is not even aware of that, and so they don't lose their funding. So by the time CMMS comes to look at them, they're meeting all their JCAHO standards. CMMS just goes, okay, well, if you're meeting theirs, you're definitely meeting ours. So getting that Joint Commission accreditation is, somewhat important, and that's why hospitals covet it so much. But understand that JCAHO is a third-party agency that, makes their money by enticing hospitals to want their accreditation rather than, basically rolling the dice with CMMS. But one of the major ways they get their information, yes, they come through the hospital and they talk to people and they quiz you on the spot about various and sundry different things, but that's not where they get the bulk of their information. Most of their information comes by reviewing medical records and looking at how the facility is actually charting and whether or not the facility is meeting the standards that they are supposed to meet. While JCAHO people come on site and do a site visit for a couple of days, usually the hospitals have to send them documentation in advance of how they are documenting in medical records, and that's something that they are looking at well in advance of their visit. Another reason for documentation is reimbursement and billing. You cannot charge for things that you haven't actually done. So if you've charged for a medication on this patient and there is no record in their medical record that that medication was given, you won't be able to charge for that. And the problem is that money then comes out of the budget for that floor. The same budget that pays for staffing and the same budget that might be so limited because of this lack of being able to capture all of the charges that they need to would mean that floor can't properly staff itself. Then everyone on that floor is running short-staffed. So clearly that's not an ideal situation. Diagnostic related groups is not something that we have to worry about a whole lot as nurses. Just understand what it's for. Basically, what it's trying to do is take a situation and predict how long a patient will need to be in the hospital and kind of about how much it will cost for their hospital stay. It's an insurance thing, and so what they're going to do is say you have a patient who's in for a mastectomy. Then they have a kind of a a roadmap of how long that patient should be in the hospital, what expenses they expect that patient to incur, and that insurance company can then kind of decide how much out of pocket that they're going to have for that situation. Now, granted, there are people that kind of, fall outside those boundaries. We call them outliers, but most people are going to follow within those guidelines in that diagnostic related group. That helps to insurance companies to predict how much money they're going to be paying out, and that drives your premiums. So obviously they try to get those, pretty close to where they are supposed to be. So what are some problems with charting? Well, having an adequate amount of time to chart. This is an issue because nurses are busy. We are running around. We have 1,000 things to do. Unfortunately, those 1,000 things that we have to do all have to be charted. So finding a quiet place where you can think without interruption is important, but almost impossible. If you're charting at the desk, you've got family members coming up asking questions, you've got physicians asking you questions, pharmacists asking you questions, your nurse aides asking you questions, so there's a lot of interruptions. Interruptions can obviously lead to errors and omissions, so clearly that's not an ideal circumstance. There's also limited space and limited number of computer terminals. If it's a computer chart and every single person who charts in that chart has to have access, that's a lot of people needing computer access. And there is not an unlimited number of computer terminals in a nurse's station. So, sometimes you can't just sit down and spend 3 or 4 hours looking through your patient's chart because you're just not going to be able to be on the computer that long. Another problem that we have with charting is indistinct terminology. Even while I'm having you learn all these abbreviations, and they are accepted abbreviations and they are correct, sometimes they can be used in different ways. A quick example, range of motion, ROM. That's going to be on your abbreviations list. You will be learning it. It's definitely something that you need to know. And while that is the official abbreviation for that, if you happen to be in the obstetrics area and you see ROM, it does not mean range of motion. It means rupture of membranes. So that's a good example of how even knowing the proper terminology and what it means changes based on what specialty you're in at any given time. There's also a problem with redundancy of forms. Sometimes we have, forms that everybody comes up with their latest and greatest, and by the time you're done, you're charting something, but then there ends up being 3 different places you need to chart the same thing. That can be aggravating. On a paper chart, if you don't chart it in all 3 places, then it's incomplete charting. So it's kind of ridiculous. But on a computer, one of the benefits of the computer is if I put in a blood pressure for a particular time, and there are 3 or 4 different places where that blood pressure should be charted, the computer can be programmed to automatically populate that blood pressure into all those locations, even though I've only charted it once. So that can be very beneficial. There's also a lack of uniformity between forms, but also between computer programs. Not every hospital uses the same computer program. Not every hospital uses the same forms. So you have to get used to whatever forms you're using at your facility. And heaven forbid you change jobs, because you will be starting completely over and learning all new forms and all new methods of charting. So one of our guidelines for recording is that we are very factual. Remember, we don't want to use a lot of inferences. We don't want to use opinions. We want to be very factual in what we say. So on anything that is objective, when we are trying to describe what we see, what a patient's abdomen looks like, or what a wound looks like, we need to do it in such a way that we can almost literally draw a picture with our words, meaning when that person that comes behind us and reads our charting, they've read that charting and they get a picture in their mind of what that wound looks like based on what you wrote. That is more difficult than it sounds. And we will be doing a little exercise in class to kind of demonstrate how difficult this can be. Whenever possible, when the patient states something, they'll say, they'll give you an idea of how they're feeling or what kind of symptoms they're having. I mean, obviously we're not going to take like a transcription class and write down everything they say, but those poignant things that they say that give us kind of a window into how that patient's feeling, those things should be documented, and they should be documented in quotes because they are coming from the subject. So in this example, it says, I feel dizzy when I sit up. Maybe you're going to do some assessment and potential interventions based on what that patient said. But if you didn't chart what the patient said, someone might say, well, wonder why they're doing this. And then completeness. JCAHO requires that nursing notes reflect the nursing process. And while you guys haven't had a lot of information on the nursing process yet, I promise it's coming. And part of the nursing process is to assess what's going on with our patient, kind of figure out what the problem is, then come up with a plan of care that's going to help them get better. That plan of care includes goals that we want the patient to reach, the things that we're going to do to help them reach their goals, and then an evaluation at the end of whether they actually did reach that. I promise you, you will have so much practice in this that eventually it will become second nature.